Now, the title of second presentation is Management of Acute Variceal Bleeding in a Resource-Limited Settings. Our last speaker is Dr. Tanvir Ahmad from Bangladesh. He is an assistant professor of hepatology and a transplant hepatologist attached to Bangladesh Medical University, Dhaka. He completed MBBS from Sher-e-Bangla Medical College, Borishal, and earned his MD in hepatology from Bangladesh Medical University. In April 2025, he completed a fellowship in transplant hepatology at the renowned Dr. Rela Institute and Medical Center, Chennai, India. Dr. Ahmed is deeply committed to advancing liver care in Bangladesh, spearheading efforts to establish a dedicated liver transplant team and specialized liver ICU. He currently serves as Scientific Secretary of the Association for the Study of Liver, Bangladesh, and is a life member of Hepatology Society, Dhaka. His international affiliations include APASL, ASLD, and ILTS. His clinical interests span transplant hepatology, fatty liver disease, cirrhosis, and hepatocellular carcinoma. Now, I humbly request our respected speaker to kindly come to the dais and deliver his presentation.
Thank you. Bismillahirrahmanirrahim. Thank you, Co-Chair Dr. Saidul sir. Honorable Chairperson, my respected teachers sitting in front of me, my mentors, and beloved doctors. Assalamu alaikum. My topic is management of acute variceal bleeding in a resource-limited setting. I think by this time, everybody got this book, paper. This is our position statement of Hepatology Society, Dhaka, Bangladesh. So, before going to the main topic, I'd like to ask how many of you are here, the junior doctors waiting for the BCS posting, or already came from the different Upojela or district level hospital, that is the remote places. If anybody is here, would you please raise your hand? So, just a scenario, Dr. X is working at Cox's Bazar Medical College Hospital. It's a midnight and he is encountering a patient with variceal bleeding. And the background is that this patient was having cirrhosis for the last 5 or 6 years. So look at his face. Like you and like me, nobody is raising hand. That means we are not confident. We have a lack of knowledge. So what he is doing? He's thinking, oh, I don't know how to manage a case of variceal bleeding. So I will refer him to CMCH, that is Chittagong Medical College Hospital. And same thing was done by me back in 2014 when I was posted in a village level hospital. I just give a cannula, start a fluid, and refer the patient to the higher center. I didn't do anything, but I'm sure at the end of this session, you'll have a knowledge which will change your behavior and attitude towards the managing of a variceal bleeder. So let's start. This topic already published in a PubMed Index journal, that is iLiver, in 2022. It is a position statement of Hepatology Society, Dhaka, Bangladesh. I'm not telling you in details about the cirrhosis, but in a word, in a sentence, what is cirrhosis? Cirrhosis of liver is a chronic heterogeneous condition having high mortality with a 5th leading cause of adult deaths worldwide. So in a nutshell, that is cirrhosis. We can classify the cirrhosis into 2 groups, compensated as well as decompensated. Based on this classification, child park classification, we can categorize into child A, B, and C. And among this, child A is considered as compensated, and B and C considered as decompensated. Everybody know about this classification, so I'm not going to tell you in details about the variables of this scoring system. So what are the signs of decompensation? It is for the junior doctors, those who just completed the internship working in a Upazila level hospital. The signs of decompensations are ascites, variceal hemorrhage, and hepatic encephalopathy. Well, what are the prognosis of cirrhosis? See, compensated cirrhosis, there is a child pug A, is median survival is about 12 years. On the other hand, when it becomes decompensated, it goes down to 1.8 years. So it is very dangerous when a patient comes to you with a decompensation. You have to stratify the risk. What actually happened in cirrhosis? In liver cirrhosis, there is a development of portal hypertension. And ultimately, the complication of the portal hypertension causes all the disaster. So it is a portal hypertension means there is a pressure, which we call the pleural pressure. And this pressure, we can measure through hepatic venous pressure gradient. And it has been said that it is better than the liver biopsy in predicting developments of complication of cirrhosis. But actually, it is not possible for us to measure the hepatic venous pressure gradient. The normal portal pressure is about 3 to 5. When it goes more than 5, we call it portal hypertension. But a term is a new term that clinically significant portal hypertension. When the hepatic venous pressure gradient touch 10 or more, we call it clinically significant portal hypertension. Why the term is different? Because in clinically significant portal hypertension, there is an increased risk of developing varices. Overt clinical decompensation like ascites, hemorrhage, and encephalopathy. If this patient undergo any surgery, there is a chances of post-surgical decompensation. And finally, this patient may land up into hepatocellular carcinoma, that is a liver cancer. In compensated state, a patient may develop gastroesophageal varices, that is up to 30 to 40%. But when the patient becomes decompensated, you see, the chances of developing gastroesophageal varices crosses more than 80%. So, if you look into the sign of cirrhosis from compensated to decompensated, further decompensation, you see in compensated state, first of all, there is a development of mild portal hypertension, followed by clinically significant portal hypertension. There will be varices or no varices. But when it becomes decompensated, the patient develops either hemorrhage or ascites or encephalopathy or all. But for the decompensation, the patient may come to you with a recurrent variceal hemorrhage, refractory ascites, hepatorenal syndrome, and jaundice. See, the jaundice is the grave prognosis of cirrhosis. If a patient comes to you with a jaundice, with cirrhosis, it means this patient is having severe liver dysfunction. And ultimately, and eventually, this patient may die. So, acute variceal bleeding. This state is considered as decompensation. And the 5 years mortality, when a patient comes to you only with acute variceal hemorrhage, no other sign, decompensating events, the 5 years mortality is 20%. But when this acute variceal hemorrhage with other compensating, other decompensating sign is there, the chances of mortality is almost 80%. I told you about the hepatic venous pressure gradient. When a hepatic venous pressure gradient is 20, there is a strong chances of developing recurrent variceal hemorrhage as well as death. But we can't measure it. Even in the worldwide, very few centers can measure it. But what should we do? We can measure the child birth classification that I showed you earlier. And it has been found that there is a strong association between child birth class and hepatic venous pressure gradient 20. More than 80% CTP-C patient is having hepatic venous pressure gradient is 20. So you should measure the child birth classification once you encounter any patient with cirrhosis. The 6 weeks mortality of variceal hemorrhage patient is about 15 to 25%. And our goal of treatment, what is the goal of treatment of acute variceal hemorrhage? First of all, controlling the bleeding. Second, the prevent early recurrence, that is within 5 days. And third, prevent 6 weeks mortality. That is the goal of treating acute variceal hemorrhage. Controlling bleeding, 5 days recurrence, and 6 weeks mortality. Now, how to manage a case of acute variceal hemorrhage? We can divide it into 3 parts. Pre-endoscopic management, that is the resuscitation phase, endoscopic management, and post-endoscopic management. That endoscopic and post-endoscopic management is being done by the hepatologist or gastroenterologist. But the pre-endoscopic management should be done by the primary care physician, that is you, the doctors who are working in Upazila level hospital or village level hospital. When a patient comes to you with acute variceal hemorrhage, we need to assess the patient first. Whether the patient is having any shock or patient becomes unconscious, you need to find it out first. And you have to protect the circulatory as well as the respiratory tract. If the patient is having low blood pressure, that is in shock, we may start colloid or crystalloid. Regarding blood transfusion, please remember, for the patient with cirrhosis having bleeding, we follow the restrictive pattern of transfusion, not the liberal pattern. What is the restrictive pattern? It means we need to give blood when it becomes less than 7. But if it is more than 7, we should not give any transfusion to the bleeder. But in liberal transfusion, what does it mean? It means we need to keep the hemoglobin more than 9. So what actually happens if we give the liberal transfusion in patient with cirrhosis with bleeding? It increases the portal pressure in liberal transfusion, but not in restrictive transfusion. Next, the infection. Patients with variceal bleeding are at a high risk of developing bacterial infection. So we need to start the antibiotic prophylaxis, because if we don't give an antibiotic prophylaxis, infection may cause recurrent bleeding as well as death. So what is the prophylaxis? The prophylaxis is ceftriaxone 1 gram every 24 hours for 7 days. Next, the most important, vasoactive drug. The use of vasoactive agent in acute variceal hemorrhage is associated with lower 7-day all causes of mortality and lower transfusion requirement. So we need to start the vasoactive drug. It should be started as soon as possible together with antibiotic and before the diagnostic endoscopy. What are the drugs? Terlipressin, octreotide, and somatostatin. It has been said that all the vasoactive drugs are used in intravenous infusion, and recent study found no significant difference among them Octreotide, it is not so available in Bangladesh. These are the dose for terlipressin. You need to start with 2 milligram IV every 4 to 6 hours interval, and maintenance is about 1 milligram every 6 hours interval for 2 to 5 days. And somatostatin, it is a loading dose. You need to give 250 microgram followed by 250 to 500 microgram hourly for 2 to 5 days. And regarding PPI, for non-variceal hemorrhage, PPI is very important. But for the variceal hemorrhage, and if the patient is having ascites, please, before giving PPI, you should consider, before giving long-term PPI, because there is a higher incidence of bacterial peritonitis in patients with ascites who have undergone long-term PPI. So you need to be careful for prescribing PPI a patient with ascites and bleeder. Definitely long-term. So the management will be like that. First of all, admission. Within 12 hours, you need to go for the endoscopy. So at the end of session, this is our recommendation by the Hepatology Society, Dhaka, Bangladesh. That is to start the resuscitation, that is the pre-endoscopic management at first attending hospital for saving lives. It should be started at Upazila level hospital. And to give fast dose of terlipressin at the first attending hospital if there is no contraindication like recent MI, unstable angina. যেহেতু আজকে আমাদের এখানে কোনো কোশ্চেন আনসার সেশন নেই, সবার মনে একটা কোশ্চেন জাগতে পারে যে তাহলে আমরা কি দিব না? First dose we can give even a patient who is having cardiac problem, because if the patient is having acute variceal bleeding in the form of hematemesis, you need to give at least the first dose of terlipressin at your center. So this is the algorithm. আপনার কাছে যখন পেশেন্টটা আসলো, প্রথম কাজ হচ্ছে গিয়ে আপনি অ্যাসেস করে দেখলেন যে পেশেন্ট শকে আছে কিনা, লাগলে একটা ফ্লুইড শুরু করে দিলেন। ব্লাড দিবেন, হ্যাঁ, যদি 7 এর নিচে থাকে, 7 এর নিচে থাকলে ব্লাড দিব, আদারওয়াইজ আমরা ব্লাড দিব না। ফার্স্ট ডোজ অফ সেফট্রিয়াক্সন দিব, টার্লিপ্রেসিন 2 মিলিগ্রাম দিয়ে দিব, একটা পিপিআই দিব, এরপর রেফার করব কোথায়? সেই ডক্টর এক্স এর মতো চিটাগাং মেডিকেল কলেজ হসপিটালে। সো আমরা দেখি ডক্টর এক্স, নাও হি ইজ কনফিডেন্ট, হি ইজ স্মাইলিং বিকজ হি নোজ হাউ টু ডিল এ পেশেন্ট উইথ ব্লিডিং। And he said that, I know how to manage a variceal bleeding and I will refer this case after giving the treatment. So, এই প্রোটোকলটা আমাদের যারা জুনিয়র ডক্টর রয়েছেন, বিভিন্ন উপজেলা লেভেল হাসপাতালে কাজ করছেন, সিম্পলি এই প্রোটোকলটা ফলো করবেন। আপনাদের কাছে একটা আর্টিকেল দেওয়া হয়েছে, আর্টিকেলের পিছনে ফ্লো চার্টটা রয়েছে। আপনারা যদি চেষ্টা করেন তাহলে আমরা কিন্তু এই ভ্যারিসিয়াল ব্লিডিং এর পেশেন্টগুলোকে তাদের লাইফ সেভ করতে পারবো। এখন আসি একটা রিয়েল লাইফ স্টোরি নিয়ে। খেয়াল করে দেখেন, 4টা SMS রয়েছে এখানে। আমি 16 মার্চ 2025, আমি তখন ইন্ডিয়াতে ছিলাম। আমার একটা পেশেন্ট ছবি দিয়েছে যে স্যার বাবার রক্তবমি হচ্ছে। তো আমি প্রথমে ওর ফোন ধরিনি, এরপর সে মেসেজ পাঠিয়ে যে স্যার একটু দেখেন। তো আমার মনে হলো যে আমাদের তো একটা প্রোটোকল আছে। আমি সেই সময় দেশের বাইরে ছিলাম, বাট আমার মনে হচ্ছিল যে আমরা যদি প্রোটোকলটা শুরু করি কি অবস্থা হয়। তো আমি তাকে ফোনে বললাম যে এই করতে হবে, এবং তাকে লিখে দিয়েছিলাম যে আপনি একটা নিকটস্থ হাসপাতালে যান, গিয়ে আমার এই মেসেজটা দেখান, ওদেরকে একটা সেফট্রিয়াক্সন দিতে বলেন, একটা পিপিআই দিতে বলেন, আর টার্লিপ্রেসিন আপনি 1 বা 2 মিলিগ্রাম যাই পান দিয়ে আপনি ঢাকায় চলে আসেন। 7 ঘন্টা পরে যখন সে ঢাকার একটা টার্সিয়ারি লেভেল হসপিটালে আসলো, সে আমাকে মেসেজ পাঠিয়েছে, স্যার অলরেডি অ্যাডমিট করা হয়েছে, স্যার আপনাকে ধন্যবাদ। এইটা ছিল আমার লাইফের একটা অনেকগুলো ঘটনার মধ্যে একটা সেরা ঘটনা, যে আমরা যে প্রোটোকলটা তৈরি করেছিলাম এই প্রোটোকলের মাধ্যমে একটা পেশেন্ট তো সেভ হয়েছে। এবং আমি দেখেছিলাম যে ভিসি স্যার রয়েছেন, আমি কখনো এই প্রোটোকলটা স্যারের সামনে প্রেজেন্ট করতে পারিনি, বাট এই প্রোটোকলটার ব্রেন চাইল্ড বা মাস্টার মাইন্ড হচ্ছেন ভিসি স্যার ছিলেন, বাট এই পর্যন্ত কখনোই স্যারের সঙ্গে প্রেজেন্ট করা হয়নি। তা ভেবেছিলাম যে আজকে স্যার থাকবেন, বাট স্যার হয়তো চলে গিয়েছেন। তো আজকের এই শেষ সেশনটার মাধ্যমে, শেষ টপিকটার মাধ্যমে যদি আমরা এটা শিখতে পারি যে কিভাবে অ্যাকিউট ভেরিসিয়াল ব্লিডিং আমরা উপজেলা লেভেলে ট্রিট করতে পারবো, সেটাই হবে আমাদের সোসাইটির সার্থকতা। এই বলে আমি শেষ করছি। ধন্যবাদ সবাইকে। আসসালামু আলাইকুম।